is Dr. Linda Gutierrez, and I am a clinical pharmacist at a federally qualified health center with clinics in Middletown and Franklin, Ohio, called CenterPoint Health. I am also a pharmacist at St. Vincent de Paul Charitable Pharmacy in Cincinnati, Ohio. And today I will be talking about medications for type 2 diabetes and the Omnious Octet. And the Omnious Octet was a term coined by Ralph DeFranco, who is an endocrinologist and researcher. He described 8 defects in the body that result in increased blood sugar. So from this presentation, I hope you will be able to identify the defects in organs that lead to high blood glucose, understand why multiple medications are often needed to control high blood glucose, and know medications that are used to treat type 2 diabetes. I made this presentation because I have had several questions from patients about why they have to take so many medications. So in Ohio, as a pharmacist, I can prescribe medications. I have a consult agreement with the providers at our clinic that allows me to order medications and order labs. And often when I start a new diabetic medication in a patient, the patient's first question is, oh, so I can stop my old medication? And often the answer is no. Patients with type 2 diabetes often need multiple medications because they work in different ways, affecting different areas of the body to help lower blood glucose. And so I hope after this presentation, you'll understand more about the medications and you'll understand why multiple medications are often needed for type 2 diabetes. So here's an overview of the Omnious Octet. And so we'll be talking about different organs, different types of cells that are affected. So the gastrointestinal tract is affected. There's hormones called Ancretins. So in those with type 2 diabetes, there's decreased Ancretins, which results in high blood glucose. There's also an increase in the breakdown of fat, so more fat's broken down, and that also results in hyperglycemia or high blood glucose. And then the kidneys increase glucose reabsorption as well, resulting in higher blood glucose. And then the skeletal muscles, they, in those with type 2 diabetes, there's a decrease of glucose uptake in our skeletal muscles. The brain is also affected as well. So there is a neurotransmitter dysfunction in the brain. And then in the liver, there's increased hepatic glucose production. So more glucose is being made by the liver. And then the alpha cells and beta cells in the pancreas are both affected. So there is increased glucagon secretion from the alpha cells, and then also impaired insulin secretion in the beta cells. And both of these things result in hyperglycemia. So we'll be talking in detail about these defects and also about what medications help these different defects as well. So first off, we'll start off in the liver. So the liver produces more glucose in those with type 2 diabetes. For a person with diabetes weighing around 175 pounds, an extra 25 to 30 grams of sugar is produced at night during sleep. And those with diabetes, there is insulin resistance, where the liver can't easily take up glucose from the blood. So we have medications that affect the liver. So metformin and POCLWD inhibit the liver for making so much sugar. And then both are potent insulin sensitizers in the liver. So they allow glucose to enter the liver more easily. And insulin acts like a key. It lets glucose inside the cells, so it doesn't hang out in the blood. And so when we have metformin and POCLWD, those medications, in a way, maybe you can think of it as like you're putting some oil on the key, so the insulin or the key can work better, so the glucose can go inside the cell and not hang out in the blood. And this results in lowering blood glucose. So there's two medication classes, and metformin is a biguanide. And common side effects of metformin, we can have some gastrointestinal effects like diarrhea, nausea, vomiting. Typically, this can be reduced by taking it with food. And then with metformin, there is also the extended release version that tends to have less gastrointestinal effects. Metformin decreases A1C by about 1 to 1.5%. And then the other class of medications we call TZDs. And so we have POCLWD and Avandia. In practice, I see POCLWD being widely used. I don't see Avandia being used these days anymore. Avandia is not available as a generic medication, so it's much more expensive. POCLWD is available as a generic medication, so that one I do see being used in practice. The most common side effects for the TZDs, you can possibly get edema, fluid retention, weight gain, and the TZDs lower the A1C about 1 to 1.5%. And then moving on from the liver to the kidneys. The kidneys reabsorbed more glucose in those with diabetes, and 90% of glucose is reabsorbed by SGLT2 transporters in the kidney and 10% by SGLT1 transporters. Instead of dumping glucose in the urine to correct high blood glucose, the kidney chooses to hold on to the glucose. So we have medications now that affect the SGLT2 transporters. So these medications block the SGLT2 receptor, allowing more glucose to be secreted from the urine. Examples of these medications are Farxiga, Invokana, Jardiance, Sliglatro. The most common side effects, I especially see this in women, are yeast infections. They can also happen in males as well, especially uncircumcised males. You can also see urinary tract infections. With this medication, it's really important to stay well hydrated. It can cause you to pee more frequently. And so it's important that when you're on this medication that you drink plenty of water, and it can lower A1C about 0.5% to 0.8%. And muscles are affected as well in those with type 2 diabetes. So muscle is unable to take up glucose well, severely resistant to insulin. And so insulin is unable to activate the insulin receptor that allows glucose to enter the cell. So medications that can help the insulin work better so that glucose can enter the muscle are POCLWD and Metformin. POCLWD is a potent insulin sensitizer, while Metformin is a weak insulin synthesizer. So both of these medications can help the insulin work better, so it can enter the muscle. However, POCLWD is going to be the potent one. And the gastrointestinal tract, so it's also affected. Here we're going to talk about our Ancretins. So an Ancretin is a hormone like GLP-1. It's a hormone produced mostly in the small intestine when food is eaten that causes an increase of insulin release. And it also slows down the emptying of the food from the stomach to the intestines. Also results in a decrease in appetite and a suppression of glucagon. And glucagon tells the liver to make more glucose. So in those with diabetes type 2, there is a deficit of GLP-1, resulting in higher blood glucose. So we have two main classes of medications that affect the GLP-1. First, we have our Dpp4 inhibitors. So these medications prevent the breakdown of our endogenous GLP-1. And examples of those medications are Januvia, Tradjenta, Onglyza, Nesina. And they're very low, have little to no side effects. And the trials, the drug manufacturers are required to report all side effects. So the most common reported side effects were headache and cold symptoms, but very low side effect profile. And they lower the A1C about 0.6% to 0.8%. And then we have our GLP-1 receptor agonists, and examples of those are Victoza, Byetta, Bydureon, Ozempic, Rybelsus, Trulicity, Adalimumab. Now, Dpp4 inhibitors, those come in tablets. GLP-1 receptor agonists are mostly injections. So you have once daily injections. You have, they also come as once weekly injections. There's one that's twice daily injection. And then and recently, or fairly recently, there has been an oral tablet, Rybelsus, that's come out. And side effects for these medications, you'll have gastrointestinal side effects. So you can have nausea, vomiting, diarrhea. And I usually counsel my patients when they feel full to stop eating. Generally, if you eat the normal amount of food, then you typically would experience nausea. So I usually counsel them when they stop eating, when they feel full, to stop eating. And then with this medication, weight loss is also fairly common. And it lowers A1C at 0.8% to 1.6%. And then we'll talk about fat cells. So normally insulin causes uptake of glucose and fatty acids into fat cells, resulting in triglyceride synthesis or fat storage. It suppresses the breakdown of triglycerides into fatty acids and glycerol. However, in those with diabetes, triglycerides are broken into fatty acids and glycerol, even with insulin present. High levels of fatty acids cause more production of glucose, inducing insulin resistance in the muscle and liver, and impair insulin secretion. So medications that affect fat cells or TZDs. So POCLWD improves insulin sensitivity in fat. It inhibits lipolysis, or the breakdown of triglycerides into fatty acids and glycerol. It mobilizes fat out of liver, muscle, and beta cells. And then in those with type 2 diabetes as well, the beta cells of the pancreas are affected. So beta cells often fail to produce enough insulin. Often when diagnosis of diabetes is made, over 80% of beta cell function has been lost. There is an age-related decline in beta cell function. So as we age, our beta cell function declines. There's also a genetic basis for beta cell dysfunction in those with type 2 diabetes. So it's very common for somebody with type 2 diabetes to also have family members as well with type 2 diabetes. And then free fatty acids also impairs insulin secretion as well. So I listed the classes of medications that increase insulin secretion. I didn't include insulin, but there's several different types of insulin, and we use insulin when we don't have enough of our beta cell function as well. So one class of medication that results in the increase of insulin secretion are sulfonylureas, such as glipizide, glyburide, and a common side effect can be hypoglycemia. So usually, if I prescribe this medication, I counsel my patients to always eat after they take this medication. A typical thing with insulin is that it can cause weight gain. And so with sulfonylureas, since you're secreting more insulin, you can gain weight on these medications. They lower the A1C by about 1% to 1.5%. We also have meglitinides that also work similarly, increasing insulin secretion. And to have similar side effects, hypoglycemia, weight gain. Examples of the meglitinides are Prandin and Starlix, and they can lower the A1C about 0.6% to 1.5%. And then we have the Dpp4s and GLP-1s that result in increased GLP-1, and GLP-1 causes the pancreas to release more insulin when we eat food. So it's based on GLP-1, it's based on food. So these medications by themselves don't typically cause hypoglycemia because you're only releasing more insulin when you have food on board. However, the other medications, sulfonylurea, meglitinides, when you take them, you're just telling your pancreas to release insulin, and it's up to you to take the food. But the others, the Dpp4 inhibitors and GLP-1s, they work when result in increased insulin secretion when there's food on board, so less likely to cause hypoglycemia. And Dpp4s, again, very low on side effects, and GLP-1s, again, can have our gastrointestinal side effects. Then we have the alpha cells of the pancreas. So the alpha cells, they release glucagon, a hormone that leads to increased blood sugar. So alpha cells secrete too much glucagon in those with diabetes. And then glucagon causes the liver to produce more glucose, so higher blood sugar levels. So medications that decrease our glucagon secretions are going to be those, again, that affect a GLP-1. So we have, again, our Dpp4 inhibitors, and then we have our GLP-1 receptor agonists. And then we have the brain. So in those with diabetes, there is insulin resistance in the brain. So glucose isn't able to enter the brain cells as easily. And there's also neurotransmitter dysregulation. So there are lower levels of dopamine and serotonin. And GLP-1, besides being produced in the intestines, like we talked about, it's also produced in the brainstem. And there's receptors in the brain that regulate appetite. So medications that affect the brain. Again, we have our GLP-1s, like we talked about, how it could affects appetite. And then our Dpp4 inhibitors, again, those also result in increased endogenous GLP-1. The Dpp4s that prevent the breakdown of the GLP-1 that we produce in our bodies. And then, besides the GLP-1s affecting the brain, we also have another medication class called dopamine receptor agonists. And dopamine receptor agonist is bromocriptine. This medication, in practice, I've actually never seen it prescribed. It is in the endocrinology guidelines still, so it's still an option. It's in reality, in practice, it's not used that often. That's perhaps because it only lowers the A1C by 0.3% to 0.5%. We have medications that lower the A1C more, but it is still an available option. So I have a question for you. So which medications would never be used together? So this is actually a really tough question. I see physicians making this mistake quite often. I've even seen pharmacists who don't catch this error. I've called many pharmacists at several pharmacies. And I've, as a pharmacist, seen several physicians make this error. So it is a really difficult question, but I hope that you should be able to answer it. Just some pointers. We never want to use medications with that work together, that work very similar in similar ways. We want to use medications that affect different areas of the body. So I will give you a few seconds to think about it, and then we'll go over it. So A is a metformin and pioglitazone. B, Januvia and Victoza. C, glipizide and metformin. Or D, Jardiance and Ozempic. So which medications should not be used together? Okay, and the correct answer is B, Januvia and Victoza. They both result in increased GLP-1, so they work in very similar ways. Januvia is a Dpp4 inhibitor, so it prevents the breakdown of the natural GLP-1 that our bodies produce. And then Victoza is a GLP-1 receptor agonist. And so we want to combine medications that help fix defects in different areas. So the other medications and the other choices, those are acceptable to be used together. Studies have shown that when you add Januvia to Victoza, there's no additional benefit. And because since they have such similar, they work very similar with the GLP-1, so we wouldn't want to use it together. So in summary, the liver, kidneys, brain, muscles, fat, gastrointestinal tract, and pancreas are involved with type 2 diabetes, resulting in elevated blood glucose levels. Multiple medications are often needed to affect different organs in order to lower blood glucose. And here I have references. Again, a large part of this presentation was based on Ralph DeFranco's paper. And if you have any questions, please send me an email at linda.gutierrez@centerpointhealth.org. I hope you're having a great day. I hope you're enjoying all the talks. And thank you so much for listening to my presentation. And I hope that you continue to enjoy the People of Color Living with Diabetes virtual summit. Yeah, thank you so much. And again, please email me and I will be happy to answer your questions. Thank you. Have a great day.